Assalamualaikum. Good afternoon, everybody. Today, I'm gonna discuss about a journal entitled Diagnostic Errors in Pediatric Critical Care, a Systematic Review, authored by Doctors Christina Sifra, Jason Custer, James Hardeep Singh, and Dr. James Fackler, published in Pediatric Critical Care Medicine this month, August 2021. So by definition, diagnostic, I cannot remove the So diagnostic error is defined as failure to establish an accurate and timely explanation of a patient's health problem or to communicate that explanation to the patient. This is definition from National Academies of Sciences, Engineering, and Medicine. This is a private nonprofit organization of three fields composed of doctors, scientists, and engineers. Mainly, they are concentrating on making innovations and researches as well as advanced studies on these three fields. So that's the definition. So what are the risk of diagnostic error in critically ill is potentially high because there's a need for immediate delivery of complex care by multidisciplinary teams to critically ill children who cannot participate in their own care. And also because diagnosing acutely ill children can be difficult because of these three reasons. First one, because children vary widely in age and development. There's neonate, there is toddlers, there's infants, and adolescent age, so different ages. Second is they are dependent on their caregivers to articulate their symptoms. Usually they will just cry, they will just mumble, but they are unable to directly communicate what are their symptoms. And they can be ill from a broad range of problems of varying severity. Like there is mild, moderate, severe severity of their diseases. There is also overlapping signs and symptoms of two syndromes or disease processes. Uh, this is the research in context. So why they did this study, this systematic review, because this is a research to understand diagnostic errors that has advanced in the past decade, but little is known about diagnostic errors in critically ill children. Harmful diagnostic errors occurs up to 48% more often in intensive care than in general inpatient wards, but specific factors in critical care that predispose patients to diagnostic error remain unknown. This systematic review summarizes current knowledge of diagnostic errors in PICU and proposes research directions to mitigate or to lessen diagnostic error-related harm. So what is the objective of the study? The objective is to summarize the literature on diagnostic error in the PICU with regards to these three factors, with regards to prevalence, impact, and contributing factors. So we're gonna discuss one by one what are the findings of this systematic review in regards to these three things: prevalence, impact, and contributing factors. And the aim of this study is to describe the state of the science, identify gaps in knowledge, and inform future directions for research necessary to understand and prevent diagnostic error and mitigate associated harms to critically ill children and also their families. So what are the materials and the methods? So this is a systematic review to summarize literature on diagnostic errors in the PICU. And this study was reported in accordance with preferred reporting items for systematic reviews and meta-analysis guidelines. So what was the search strategy? They searched from PubMed, Embase, and Cochrane Library through December 17, 2019 for all studies on diagnostic error and diagnostic processes in pediatric critical care settings and population. They use the terms to search. To search for their study, like misdiagnosis, diagnostic errors, diagnostic delay, ICU pediatric, PICU, critical care, and pediatrics. So how did they review the studies? They use the following review and inclusion exclusion criteria. The three authors with the three authors of the study. CLC stands for Christina L. Cipra, one of the authors. She screened the abstracts to exclude duplicate articles and case reports or case series. Dr. Cipra, together with Dr. JWC, Jason W. Custer, they excluded studies describing non-PICU populations, studies focused on a single condition or disease or a single diagnostic test or tool, studies focused on treatment with no original data, and studies not focused on diagnostic error or diagnostic processes. Then at the end, the third author, Dr. James C. Faulkner, he adjudicated all disagreements by the two reviewers. So he was the judge, whatever will be the disagreements between Dr. Cifra and Dr. Custer. So after a full article review, additional studies were excluded by consensus based on the above criteria, and non-English language studies without English translations were excluded. This is the summary, this is the flow diagram, how they come up with the studies that were included in the systematic reviews. Initially, there were about around 396 studies that were included as they have searched from PubMed, Embassy, and Cochrane Library. Then after applying the exclusion criteria by screening the abstracts, further 110 articles or studies were duplicated because of excluded because of there is some duplications, there is some case reports and case series. So after excluding this, they came up only with 286. Further review, they were able to exclude another 256 articles. Those who did not include in the PICU population focus on single conditions or diseases only. Those are focused on treatment only, and those who doesn't have original data. And after that, only 30 studies were included. Then another review, after they have reviewed their full articles, they excluded again 13 studies, those who are not having English translations, and those who are do not include PICU population or no information on the diagnostic error. So at the end, the final studies included were only 17 studies. Data abstraction and synthesis. Each article's full text was reviewed, collected data on research design, primary objective, and study population. They reviewed each study for available data on the prevalence of diagnostic error, taking into account the relevant denominator on and how diagnostic error was determined, common misdiagnosed medical condition, and the time of recovery of error. They collected data on the consequences of the diagnostic error, including the morbidity and mortality. And autopsy studies in particular describe also discrepancies between the autopsy and clinical findings using the Goldman classification system, wherein major diagnoses are categorized as either class 1 or class 2. They categorize it as class 1 if there was a potential adverse impact on survival and would have changed the medical management. They classified it also as class 2 if there's no potential impact on survival and would have not have changed the therapy. Um, Data were also collected concerning the factors associated with the diagnostic error. And there were uh, actually three factors that are associated with diagnostic error. One is cognitive factors. These are that are contributing to misdiagnosis, including errors in clinical reasoning and knowledge gap. Systems errors are these systems factors. These are includes the organizational vulnerabilities, including structural and workflow issues. And the third factor associated with diagnostic error is the combination of both, a combination of cognitive and systems factors. Um, With regards to the results from the flow diagram with the 396 publications, they ended up with 17 studies that are included in the systematic review. With this total 17, 14 had full text and 3 had only abstracts. 15 were had observational study design. 13 studies included in PICU patients as subjects, whereas the rest are included are PICU clinicians. 13 provided information on the prevalence of diagnostic error, most commonly from autopsies or chart reviews. 8 studies provided some information about the factors associated with diagnostic error, and 3 studies had data on the consequences of diagnostic error. So we're gonna discuss one by one the results of the systematic review with regards to the prevalence, the impact, and the factors associated to the diagnostic error. So with regards to the prevalence error, they reviewed autopsy studies, retrospective cohort studies, and other studies. So with the prevalence diagnostic error in the PICU, they have seen diagnostic error in autopsy studies. First, there were 4 autopsy studies. And out of these 4, the most comprehensive one is the one done by Dr. Castor et al., wherein he did a systematic review of 7 PICU autopsies. And this study found out that there is a 20% major diagnostic error rate with class 1 diagnostic error of 6%. And the most common major misdiagnoses were infection, cardiovascular events, and congenital malformations. Common examples of this are the unidentified catastrophic hemorrhages or thrombosis, missed bacterial sepsis or meningitis, and inadequate delineation of congenital heart disease anatomy. So this is with regards to the autopsy results. With regards to the retrospective cohort studies, Dr. Sifra in 2018 had studied 50 patients who are admitted to PICU with consecutive admissions, and this study found out that there is an 8% diagnostic error rate in the first 12 hours of PICU admission. But 75% of these patients were diagnosed correctly between 1 and 3 days after the admission. And the most commonly misdiagnosed conditions are mostly neurologic and infectious in nature. Also, the study of Dr. Dabalos et al., wherein he hypothesized that he had 214 patients admitted to a PICU, wherein he hypothesized this patient to be at high risk for diagnosis error, found that there is a 12% overall diagnostic error. And most commonly misdiagnosed conditions were mainly neurologic and infection and GI conditions. particularly highlighting delays in diagnosing septic shock and increase in intracranial pressure. We are still on the retrospective studies. There were 3 studies on mortality and morbidity conference. This one, the study done by Dr. Sipra, 2 studies by her, and 1 study by Dr. Afray. They found out in this during the mortality conference that um, the there were overall studies of M&M conference showed that there is 21 to 25% diagnostic errors with mainly adverse events of around 7 to 25%. And most commonly misdiagnosed conditions are mainly vascular and neurologic diseases. This study by there are 2 studies that look into the discrepancy of the interpretation of X-rays between PICU and the radiologists, mainly chest X-rays and abdomen X-rays. And there is a discrepancy rate of around 7 to 46%. And 9 to 13% are actionable discrepancies. Like the most common actionable discrepancies were line and tube placement and misinterpretation of lung findings, whether it's an airspace disease, atelectasis, or effusions. Other studies were authored by Labib et al. This is a prospective study wherein the incident reporting of 215 incident reports found around 5% diagnostic errors. And also, Bat et al. Did a survey of 200 pediatric cardiac ICU clinicians, including nursing staff. And in this study, the prevalence of diagnostic error was 79%. They reported that 79% of the respondents reported that they have encountered at least more than 5 diagnostic errors yearly. Some reported 65% of the respondents reported encountering more than 5 harmful diagnostic errors also yearly. Most of the misdiagnosed or errors they have found in this study was mainly medication errors, some psychiatric conditions, and also sepsis. Those are the results with regards to the prevalence of diagnostic error in PICU. Second is the impact of diagnostic errors. There were only 3 studies that shed light to the consequences of diagnostic errors for the ICU patients, and none illustrated the impact of diagnostic errors in PICU on PICU clinicians. Only in 1 study, 60% of diagnostic errors caused patients of having with around 25% severe enough to have potentially contributed to death. And in the survey of pediatric cardiac ICU clinicians, 16% of the respondents perceived that greater than or equal to 5 diagnostic errors cause severe permanent harm per year. Diagnostic errors discussed on M&M conferences all prompted interventions to mitigate future errors. We'll look also on to the results regarding the factors associated to diagnostic error, whether it's a cognitive factor, system factor, or combination of both cognitive and system factor. So for the cognitive factors, there are 3 studies. These 3 studies of Bat et al., Sipra et al. It showed that there is 20 to 33% of the diagnostic errors were due to clinicians' cognitive errors. And these factors includes inadequate data assessment, anchoring on one diagnosis, provider inexperience, they have problems in hypothesis generation or inadequate differential diagnosis. And also they have suboptimal diagnostic evaluations given available clinical information, especially information from the patient history. Doc Su et al. Uh, he did a video review real time at bedside, and with this study, with this video review, they found out unexpected clinical events like delay in recognizing an anticipated cardiac arrest despite objective findings. And there's also false reassurance from the presence of other clinicians, lack of specialized knowledge, or lack of expertise. Uh, in the these are all the findings with regards to the cognitive factors associated with diagnostic errors. With regards to the system factors, two studies, one study by again Dr. Cipra and Bat et al. These system factors showed around 40 to 67% of diagnostic errors were result of system problems. The one done by Dr. Shipra showed that in her retrospective chart review showed that night shift admissions is one of the factors associated with diagnostic error. And the one done by Bat et al., which is a self-reported perceptions of a pediatric cardiac ICU clinicians, showed that there is a delay in obtaining diagnostic studies due to inability to travel off unit for unstable patients. And there is suboptimal care coordination related to deficiencies in communication and teamwork, and also frequent interruptions to workflow. These all are factors associated with diagnostic errors. For the combined cognitive and system factors, there are two studies authored by Avisar and Cipra, again, Dr. Cipra. And in the study by Avisar et al., wherein they analyzed the behavior of the clinicians, and they found out that the factor that associated with diagnostic errors was the work environment and culture that influenced clinicians' decision to challenge existing diagnosis. Like if the during handoff, the one of what if a PICU clinician show rudeness during handoff, this will lead to unwillingness of clinicians to challenge an inaccurate diagnosis. The second one is by again by Dr. Cipra, wherein they analyzed the analysis. She did an analysis of ethnographic data. She reviewed the clinicians' observations and interviews gathered during patient admission to the PICU. The one of the factors that associated with diagnostic error is the characteristics of referral communication between clinicians, the patterns of communication of patient data to trainees to intensivists, and manner in which health information technology organizes and presents clinical data that influence intensivist diagnostic decision making. So with the discussion of this systematic review, they demonstrated that there is a large gap in the knowledge of diagnostic error in the PICU. They also illustrated that the challenges of synthesizing data from a limited number of studies with heterogeneous study design, study samples, data sources, and data collection procedures. This system review affirms that diagnostic error are important problem in pediatric critical care, and further inquiry into how diagnostic error occur is warranted to prevent and mitigate them in critically ill children. So they have listed some of the gaps in the knowledge or the missing link to our full understanding of the diagnostic errors in PICU. One of the gaps is much information on diagnostic error is limited to PICU mortalities due to over-reliance on autopsy studies. Um, Second is there is unknown prevalence of diagnostic error across large general PICU population and across subpopulations like the ones in cardiac ICU, trauma, and sepsis patients. Little is known about the impact of diagnostic error in PICU patients, their families, clinicians, and organizations. There's no Up to now, there's no conceptual model on the diagnostic process in pediatric critical care, which leaves gaps in our understanding of factors involved in the diagnostic process and potential vulnerabilities in diagnostic decision making. They have also listed some of the future directions in research, and uh, he said there should be continue efforts to increase autopsy rates in PICU while decreasing reliance on autopsy studies as the source of information on diagnostic error. We should conduct large multi-center studies including relevant PICU subpopulations to characterize diagnostic error epidemiology. To identify PICU populations, situations, and processes that are at increased risk of diagnostic error. Conduct studies to determine the impact of diagnostic error, including physical, psychological, financial harm to patients, families, clinicians, and organizations. To develop a standard diagnostic error identification and analysis frameworks that PICUs can incorporate into existing patient safety programs. Study the diagnostic process in the PICU and develop or adapt existing conceptual models of diagnosis to the pediatric critical care settings. To balance focus between studying the diagnosis of individual diseases and studying common underlying system-related causes of diagnostic error. Leverage a variety of research methods to study diagnostic error in the PICU and integrate and triangulate findings from different methods if possible. Follow standard research methodology when possible. So these are the future directions for research. This study has some limitations, and one of the limitations is that the study included were heterogeneous. And amongst the autopsy studies, there was a potential for selection bias, given that autopsy rates were less than 50%, around 48% only. Among retrospective chart review studies, there was wide variation in data sources and data collection procedures, which may have resulted in different determinations of diagnostic error and contributory factors. Studies were also conducted at different centers with varying capacities for staffing, including training oversight, diagnostic testing, and organizational factors that may have affected reported diagnostic error rates. They did not formally assess or restrict the quality of included studies, and there is a possibility that authors may have misclassified diagnostic errors. So what does this study may add to us? So diagnostic errors are serious and prevalent problem in pediatric critical care, but persistent knowledge gaps of how and why they occur remain unknown. The strategies to close these knowledge gaps include identifying errors extending beyond autopsies, multi-center efforts to delineate diagnostic error epidemiology, and employing disease agnostic approaches that account for underlying systems and process factors affecting PICU diagnosis. PICU leaders and staff can develop local programs to identify and analyze diagnostic errors. And we need PICU collaborations and professional organizations that can support multidisciplinary work, balancing disease-oriented research and system-oriented investigations into the PICU care delivery processes and that affect our diagnosis. So in conclusion, there's still a large gap of our knowledge of diagnostic error in the PICU, although we do know that diagnostic errors are common and may cause harm in our critically ill children. Future directions include the development of local programs to identify and analyze diagnostic errors and the creation of research opportunities. All of these actions can advance our understanding of how diagnostic errors occur in the PICU and help prevent and lessen the impact of our patients on our patients and their families. Um, Thank you. This is the end of my presentation.